Okay, we're going to start chapter 25, and this is a really, really important chapter. Again, it's going to be a basis for almost everything that you do in healthcare. It is absolutely essential that you understand cardiopulmonary functioning and how to assess it in your patient. So I want you to read this chapter. It's really important. A couple things that I'm going to point out that we're going to talk about in detail. If you look at the glossary, I'm on page 654 right now. We're going to talk about acute coronary syndrome, and basically that's a heart attack. That's an MI. We call it acute coronary syndrome now. It's typically caused by a blockage in one of the coronary arteries that feed the heart. You'll remember when the left ventricle ejects blood into the aorta, there are branches off of that aorta that come around and feed the outside of the heart. Those are your coronary arteries. Those tend to get fat and cholesterol deposits in them, and they block those arteries, and then the blood can't get through there, and then the cardiac muscle can't get the oxygen, hence the heart attack. So we call it acute coronary syndrome. We're going to talk about afterload, preload, cardiac output, contractility, systemic vascular resistance, central venous pressure. These are some words that you need to have in your vocabulary as a nurse. Because everything you do with your patient is going to affect some of those parameters, and you need to understand what's happening with your patient. So read through the first couple pages. You should know anatomy of the heart. Okay, I want to direct your attention to figure 25.1 on page 656. It is essential that you understand and keep in mind the pathway of the blood through the heart. Students mess this up all the time. The reason this is important is because you need to understand if your patient has a DVT, a deep vein thrombosis, meaning they have a clot in one of their veins, those veins are coming back up to the right side of the heart, and that clot is going to pass through the veins up into the subclavian vein, which dumps into the right atrium, dumps into the right ventricle. That goes to the pulmonary system. You're going to have a PE, a pulmonary embolism. It can't get all the way through the lung system and then back into the left atrium, left ventricle. So a PE deep vein thrombosis is not going to cause a stroke, but it will cause a PE, a pulmonary embolism. If your patient has a clot on the right side of the left side of the heart, so like if they have AFib or something, and they develop a clot in the left atrium, and that goes to the left ventricle, that's going to go out through the arterial system, and now you're going to get a clot somewhere in the arterial system, so that's going to be in the systemic system, not in the pulmonary system. So you kind of have two systems that you need to keep in mind. You've got the pulmonary system and the systemic system. Really important that you keep those two things differentiated. So make sure that you understand the anatomy of the heart. We're going to talk in a couple more weeks about inflammatory diseases, valve problems, and so you really need to understand which valve is where and what's going to what in the heart. So I want you to make sure that you're pretty familiar with figure 25.1. The next thing I wanted to point out, let's go over to cardiac hemodynamics on page 659. Okay. This gets confusing, but it is absolutely essential that you understand what we're talking about. All right. So the first thing that is important for you to know is something called your cardiac output. Now, I'm going to draw up here. This is your heart, like this. And these are the four chambers of your heart. So this is your right atrium, right ventricle. This is your pulmonary artery, and it goes out here to the lungs. Okay, remember this. This right ventricle goes out to the lungs through the pulmonary artery, and it comes back through the pulmonary vein into, this is the pulmonary vein, it comes into the left atrium, left ventricle, this is your big guy, this is the big gun right here, and then it goes back out through the aorta, up, goes up into, you've got your carotid arteries, and then part of it goes down. You've got, your aorta that goes right through the core and down to your legs. Okay. Your cardiac output should be between 4 and 8 liters per minute. And that is the amount of blood that is ejected from the left ventricle every minute. And normal is between 4 and 8 liters. This is essential. Your cardiac output is everything, because if your cardiac output starts reducing, what that means is every time this left ventricle is filled with blood, and it fills up during diastole, and then it contracts during systole, that's your blood pressure. So it's like, it should be, during systole should be about 120 millimeters of mercury. During diastole is about 80. We'll talk about more of that when we're doing hypertension. When it contracts, it is ejecting blood into the arterial system, and that blood is carrying oxygenated cells so that all of your cells who are waiting for the oxygen can get it. When this starts reducing, every organ is hypoxic. They're not getting the oxygen that it needs. So it is essential that you maintain cardiac output in your patient. And we're going to talk a little bit about how to do that. But this cardiac output, essential. You cannot forget cardiac output. It's a measure in liters per minute. Okay, that's your cardiac output. The next thing you need to know is stroke volume. Okay, it's approximately 150 mLs per beat. Okay, so your stroke volume and your cardiac output are kind of a measure of the same thing. Your stroke volume is a measure of how much blood is ejected per beat, and the makeup of this equals your cardiac output. So you take your stroke volume, multiply it by your heart rate, and you can get your cardiac output. And you don't need to know that formula as much, but just remember, stroke volume is the amount of blood ejected by the ventricles per beat. And the same thing is going on in the right and the left ventricle. So when the left ventricle is ejecting blood into the arterial system, the right ventricle is ejecting blood into the pulmonary system. But the pulmonary system, really, we are ejecting carbon dioxide rich blood into the lungs so that we can expel it and we can replace it with oxygen and bring it back into the left side. So these two things are going on, but the cardiac output is more of a measure of the left side, because we're really more concerned that our organs are getting the oxygen and not that this exchange is taking place. Although the exchange is important, and we'll talk about that when we're talking about, COPD and some of the other lung issues, that becomes a problem. So cardiac output, 4 to 8 liters per minute. Stroke volume is the amount of blood ejected per beat. Now, there's a couple other things that factor into this. One is contractility. So contractility, I'll just abbreviate it because I'm running out of space. Contractility is the amount of force exerted by the ventricles per beat. And there's a couple of factors that play into that. A damaged heart doesn't contract as strong because there are missing cells that can't help do the workload. Some medications that we put patients on will help increase the contractility of the heart. Patients who have really strong hearts, athletes and stuff, have built up this muscle, and they have very efficient hearts. It beats very strong and sometimes slower because they've got more efficient hearts. So the amount of force that is ejected by that heart muscle will affect cardiac output. So if your contractility is stronger, you're going to squeeze more blood out. If it's less strong, if it's weaker, you're going to eject less blood out. So contractility has a lot to do with cardiac output. The next thing that's really important is something called preload. Okay, this part gets a little tricky. Preload is a measure of volume. Okay. Preload is the amount of fluid in the ventricles at the end of diastole. So during diastole, when the atrium are dumping their blood into the ventricles, and when the blood is getting dumped into the ventricles, the mitral valve, in the tricuspid mitral valves are opened up. The blood is dumping in here during diastole. And these ventricles are getting all filled up. They're getting ready for the big contraction, the big systole. So these are filling up with blood here. And that amount of blood that's in the ventricles right before systole, that's called preload. That's the name of it. It's just preload. It is a measure of volume. Now, if you remember from when we talked about fluid electrolytes, the fluid status in your patient will significantly affect the preload. So if your patient is hypovolemic, they have less fluid in here, less fluid. So then when that heart contracts, there's less fluid going out, and you've just reduced your cardiac output. If your patient is hypervolemic, they have lots of fluid in here, they have an elevated preload, and when that ventricle contracts, there is more fluid going out, and you've increased your cardiac output. So you're going to have more fluid in the system if your patient is hypervolemic, less if your patient's hypovolemic, and the volume is totally a measure of this thing called preload. How loaded up are those ventricles right before systole? That's preload. There's another thing you need to know, and it's called afterload. Now, here's the tricky thing. Preload and afterload sound the same, but they measure completely different things. Preload is a measure of volume, and that's how that affects cardiac output. Afterload is a measure of pressure. Okay, two different things. This one's measuring fluid, preload's measuring fluid. Afterload is measuring pressure, because now these three things are affected. How hard is that cardiac muscle contracting? How much fluid is in the ventricle when that ventricle is contracting? But the next thing is, when these things are contracting, they're meeting resistance. They are going up against the system. Your left ventricle is going to meet the resistance of the aorta. This becomes your blood pressure. The right ventricle is meeting the resistance in the pulmonary artery and the pulmonary system. So you think of it like this. So like you've got like a balloon full of water, and now you're going to try to squeeze all that water out. What's on the other side? If you have a big opening in the balloon, it's just going to all spill out. If you have a small opening in the head of that balloon, you have to work really, really hard to get all the volume out. That's your afterload. Afterload is a measure of resistance. The higher your patient's blood pressure, and that's a measure in your arterial system. Nobody cares about the veins. The veins are over here. No, that's your ventricles don't go to veins. Your ventricles are going to the arteries, and your blood pressure is a measure of the pressure in the arteries. So if you have high blood pressure and really, really tight arteries, these are really tight in here, like that, your afterload is going to go up. If you have really low blood pressure, if your patient is like vasodilated, these vessels are dilating here, you have less resistance. It's like the balloon thing. A bigger head on the balloon is less resistance. You can get that water out really easy. When the head of the balloon is constricted, vasoconstriction, then it's going to take more force to get this fluid out. So this up here is called afterload. So keep in mind, vasoconstriction is an increased afterload. Vasodilation will reduce your patient's afterload. So these three things, your afterload, your preload, and your contractility, all factor into figuring out this cardiac output. When your afterload is high for too long, like patients who have chronically high blood pressure, that puts tremendous effort on these ventricles because they're constantly having to squeeze way too hard. This is why you want your afterload, aka your blood pressure, those are kind of the same thing, you want that to be about 120/80. That's normal. That's your normal afterload. And another thing that will help you figure out this is something called your pulse pressure. Your pulse pressure is basically you just take your blood pressure and you subtract the two. Normal pulse pressure is between 30 and 40. And when you get a measure of the pulse sorry. Okay, so when you're doing a pulse pressure, this is like your blood pressure, and then your pulse pressure is you just take, 180, you subtract that, and you get 40 millimeters of mercury, and that's normal. Your pulse pressure is a pretty good indication. Pulse pressure is a pretty good indication of your stroke volume. Okay, you can kind of tell what your stroke volume is doing, but your stroke volume is all based on contractility, preload, and afterload. So you need to understand those concepts. Now, so how do you figure this out? There's a couple of ways to figure this out. There's something called a Swan-Ganz catheter. And that is hemodynamic monitoring, and I think they show you a picture of it in your book. Yeah, it's over on page 689 and 688. I have one of these in my office. I will bring it in to show you. This is very invasive monitoring, and usually patients who have a Swan-Ganz catheter are in the ICU and hooked up to monitors so that you can see what's going on. But this catheter, it goes in through the subclavian vein, through the right atrium, into the left atrium. So it's this big long catheter. So let's say, I'm going to erase some of this stuff. My board's not quite big enough. Okay, just remember afterload is pressure. I'm going to take this off. Okay. So if your patient has a Swan-Ganz catheter, and this is going to be our subclavian vein, dumps into the right atrium. Your jugular veins come in, dump in here, like that. This catheter will come, you put it into a physician or an advanced practice nurse, or if you're going to be a CRNA, you can insert these. So it goes in through here, goes into the right atrium, into the right ventricle, up into the pulmonary system, like this. And so it sits up in that pulmonary artery. And you can tell where you are because there's different waveforms. So while you're putting this thing in, it's done under sterile techniques, usually at the bedside. This becomes, like if you end up working in an ICU, you'll help insert these. And then on the end, there's a balloon like that. Most of the time the balloon stays deflated. It's like a balloon like you on a Foley catheter, how it's deflated, then once you insert the Foley catheter, then you blow up the balloon. That's what happens here, the Swan-Ganz catheter. But you leave the balloon deflated most of the time. If you inflated it, then what happens when you inflate that balloon into the pulmonary artery is it blows up like this and it stops all the blood behind it. So you only blow up the balloon for a couple of seconds, you get your reading, and then you put that balloon back down. Otherwise, you'll infarct the patient's lungs because they're not getting blood up there. The reason this catheter is really nice is it gives you a lot of measurements, and there's a couple of measurements that you need to know. Some of these you can figure out without having this catheter in. You can't get exact numbers, but you can kind of get some ideas. So some things that you need to know about is the first thing is called your central, that's an L, venous, that's a big word, that's a big huge clue, pressure, also known as your CVP. This is your CVP, central venous, veins on the venous side, and it's all a measure of the veins coming up into the system, and it's a measure of fluid on the right side of the heart and in the venous system. You don't have a lot of pressure in the venous system. You don't need a lot of pressure in the venous system. You're not getting blood anywhere. You are returning all of the blood that has the carbon dioxide in it. So it's coming up here, getting dumped back into the right side of the heart. That's your central venous pressure, and it's low. It's usually between, this changes a little bit, but it's about 2 to 6. I think your book says 2 to 6. Sometimes some people say like 3 to 7, but your book says 2 to 6. Okay, so it's not a lot. You don't have a lot of pressure there. So when this number gets high, your patient is, if it's greater than 6, your patient is getting fluid overloaded, high fluid. When it's getting less than 2, your patient has less fluid and they're getting hypovolemic. So you can tell by this number, by getting your CVP, what your patient's fluid status is doing. And then if it's getting too high, you need to assess, okay, like, do I need to give my patients diuretics? Can I just withhold some fluid for a while? Limit their salt intake? You know, what's going on? And when this CVP is going up, you're going to see some other things. You might see jugular venous distension, because now I have a lot of fluid in here, so these veins are starting to descend. I mean, not descend, dilate. You can start hearing edema. Like, I guess you don't hear edema, but you see edema, because what'll happen is this stuff is trying to come back up, and this is down here, you know, in a foot, and so you're going to start getting edema because this is starting to back up. These are kind of things that you're going to see in your patient who has too much fluid on the right side of the heart. So it's everything before the lungs. Okay, so it's backing up, everything back up here on the right side of the lungs. Skin turgor is going to be thick. They might be peeing a lot. You know, there's anything that is associated with increased fluid on the right side of the heart. But this is your central venous pressure, and it's measured right in here. This is your subclavian vein, right atrium, jugular vein. That's all kind of the same. The same system. There's no pressures or anything in that's different. So that's your central venous pressure. Okay, then the next thing is when your patient has a Swan-Ganz catheter in, it sits in the pulmonary artery with the balloon deflated most of the time, and it can give you a reading of the afterload in the pulmonary system. It is identical to the blood pressure on the left side of the heart, but it just tells you what the pressures are doing in the lungs. And it's lower than 120/80. It's less than that because the right ventricle doesn't need to pump it as hard. It's only going to the pulmonary system. It's not going everywhere else. You're not ever going to be asked to know normal pulmonary arterial pressures, but you do need to trend if they're getting higher or lower. So if you have a Swan-Ganz catheter in, and pretty much, well, never mind, I won't tell you that. So this is a measure of your pulmonary artery vascular resistance. So it's like, basically it's the afterload in the pulmonary system. Every now and then, and it depends on how sick your patient is, sometimes it's done once an hour, sometimes done once every 4 hours. The nurse, this becomes a nursing job, you will blow up this balloon, and there's a little catheter on the end of it. I think it shows you, yeah, see the balloon inflation valve, figure F. You put this syringe in and you blow up the balloon, and you can watch on the monitor the tracing will start flattening out. And then you get your what's called your wedge pressure reading, and that's called your pulmonary arterial wedge pressure. Not to be confused with your pulmonary arterial pressures. Pulmonary arterial pressures is just like blood pressure in the left side, not using an inflated balloon. When you inflate the balloon, now you've wedged this up into the pulmonary tree. You wedged it, you've stopped all the blood flow behind it, and then there's a little transducer on the end of here, and it reads forward. So it gives you a measure of what's happening on the left side of the heart. Normal pulmonary artery wedge pressures are 6 to 12. When your wedge pressure gets too high, greater than 12, you have too much fluid on the left side of the heart. And so there's probably a backup on the left side, and your patient is probably starting to get into heart failure. So that's how you measure your pulmonary artery wedge pressure. Patients who do not have this invasive line in, you can still kind of tell what their wedge pressures are doing, but just by listening to their lungs. So if you have a patient who has a high wedge pressure, all of this fluid, the preload, is starting to back up. It's not able to eject it like it should. You've either got a problem with your afterload, your preload, or your contractility, but things are starting to back up. This left ventricle can't keep up. They can't eject all of the blood, so it's like like putting logs in a river that pretty soon now the river can't flow as much, and so everything behind that starts backing up. And you can hear it because now the fluid that's in this left ventricle, which is supposed to be going out through the aorta, is getting jammed. It's getting stuck. So it's going to back up into the left atrium and then kind of hangs out over here in the lungs because there's a traffic jam. It can't get down there as much. Now you're going to start hearing fluid. So when you're listening to your patient's lungs and you're hearing fluid, one reason could be that your patient has heart failure and this heart isn't beating or getting the blood out like it should be. So that's your pulmonary artery wedge pressure. Let me think, did I teach you everything that you need to know? Your cardiac output, I think I told you this before, your cardiac output is your heart rate times stroke volume. That equals your cardiac output. So however much is coming out per beat, you multiply that by your heart rate, and that's going to give you your cardiac output. The one little tricky thing here is stroke volume is in milliliters, and this is in liters, so you have to convert this. So you multiply by 1,000 so that you're up to your liters. Okay, so let me see. If any of you guys want to end up being a CRNA working in the OR, you have to know this 100%. So you sit and you watch this all day long, and you measure. That's what I forgot to tell you. I don't even know if it's in your textbook. There's a couple. This is really messy. All right, let me start over. The other things that I want you to know, and there's some formulas to figure this out. If you are, if you're working in the OR as a CRNA, if you're an ICU nurse or anything like that, you need to figure these out. There's different formulas. I don't know if your book goes into it or not. I won't confuse you with that. I might talk about it in class a little bit. The other things you need to know about are your systemic, I guess I'll write it out, systemic vascular resistance. Vascular resistance. This is known as your SVR. This is identical to afterload. Not identical, but similar. So this is an important thing that you need to also know in your patient. The next thing is your mean arterial pressures. Okay, and there are formulas to figure these out. Your mean arterial pressure is the average pressures on your arterial side. Your systemic vascular resistance is a measure of the entire vascular system. So you take your mean arterial pressure, you subtract your central venous pressure to get your systemic vascular resistance. This becomes important when you're trying to figure out if your patient, like what their fluid status is, are they hypertensive, hypotensive? You need to figure out what is their systemic vascular resistance doing, and what is their mean arterial pressure. So those are some words that you need to be familiar with. I don't think your book has you figuring out how to actually do that. I will double check before class. And I can show you the formulas. They're not hard. SVR gets a little bit harder to figure out. Mean arterial pressures, and that's pretty simple. We can go over that in class. So the other things I do want to point out in your book, and I'll go over this stuff with you guys again in class because I know it's really confusing when you start hearing this for the first time. You do need to understand, what was I going to say? Totally lost my train of thought. Normal heart sounds. I'm sure you guys learned this in assessment, like S1, S2, and then there's like S3, S4. Those are abnormal. Gallops, murmurs, those are a little bit abnormal. Go over common symptoms for people with coronary artery disease, coronary vascular disease. We talked a little bit about them. Really important when you're doing the health history to figure out somebody's cardiac history. What I wanted to talk to you guys about, now I can't find it. You do need to know about postural hypotension, orthostatic hypertension. That's pretty common in the elderly, so you need to figure out how to measure that. And then, not that. Okay, yeah, this is what it was. I wanted to go over some of the laboratory testing when you're assessing your patient's cardiac status, because this is so common in the United States, really, really, really common. It is very important when you are talking to your patients and getting a good cardiac history. You want to get a what's called a lipid profile, and that is to figure out what is your patient's triglycerides and cholesterol doing. cholesterol, you need cholesterol to keep yourself malleable and so that you're not all rigid. That's what cholesterol does. But too much cholesterol can't, because cholesterol is like in the lining of the tissues and the cells. But too much cholesterol can't fit, and so then it'll start lining the inside of the arteries. So then you have a patient who has like, let me erase this again. Let me show you what this kind of looks like. And this is why getting your patient's cholesterol levels are so important. So let's say that this is a normal vessel. I've cut it in half. I'm looking down at it like this. This is normal. When cholesterol starts building up in here, it does a couple of things. It can increase blood pressure, but it also puts the patient at risk, because what will happen is when these start laying down in the arteries, then the arteries start getting inflamed, which causes more swelling. Inflammation is not good in the arteries, and these things can break off. And depending on where it is in the arteries, it can break off, and that's what causes a heart attack, because this vessel is nice and big, but if this breaks off and goes down into a vessel that's getting smaller and smaller and smaller, like this, you know, way down to these little tiny arteries down here, this piece of cholesterol kind of comes down here, and it's fine. It can kind of hang out here, hangs out here. All of a sudden, it's going to get lodged right here. No more blood and oxygen can get down here, and now all of a sudden you've just got a big infarct, because this doesn't let blood get down there, and now we've got ischemia. So that's what happens in an infarction. So if it happens in the heart, you've got a heart attack. If it goes up to through the carotid arteries up into the brain, you've got a stroke. If it goes down to the kidneys and infarcts the kidneys, all of a sudden you're going to have decreased urine output and could lead to kidney failure. So it depends on what organ it lands in. But obviously the brain and the heart are the significant ones. So you want to figure out what your patient's lipid level are doing, how much fat is inside the system, and what is their cholesterol doing. There's two kinds of cholesterol, LDL and HDL. LDL is your low density lipoproteins, and that's the bad cholesterol. You want that number, you want your LDLs to be less than 70, because those are kind of like the fat blomty kind of cholesterols. And then your HDL is your high density lipoproteins, and those should be about 35 to like 70, 75, 85. It changes a little bit for men and women. And the ratio between those two is important. People who work out a lot, like high-level athletes, will have sometimes very high levels of HDL, but they usually have really low levels of LDL, which keeps their cholesterol under 200. You always want your cholesterol under 200, because there's been a million studies that will show you that high cholesterol leads to a higher risk for coronary artery disease. So that's why it's so important to keep your patient's cholesterol checked and under control. And the easiest way to do that is diet and exercise. So you want your patient on a healthy diet, carbohydrates from whole grains, lots of fruits and vegetables, that kind of stuff to keep those LDLs down. And some of that is genetic. So if your patient has a family history of heart disease, sometimes people are just born with high triglycerides and genetic predisposition for that. And then those patients have to get treated. And there's a lot of medications out now that help actually lower cholesterol, the statin drugs and stuff like that you're probably learning. I want you also to know about brain neutropenic neutretic peptide, BNP. That one is a good measure for to find out what the patient's what their like how healthy their cardiopulmonary system is. C-reactive protein is another one. The C-reactive protein is an indication of systemic inflammation. So if you get a high C-reactive protein, your patient probably has inflammation going on somewhere. Your troponin levels are very specific for the heart. So patients who have had a heart attack, they get inflammation in the myocardium, the troponin levels will increase, and so that's a good indication if your patient's actually had a heart attack or if they've had angina. I do want you to know the labs on table 25.4. We talked a little bit about these during fluid and electrolytes. You do need to know those lab values. The other ones that we didn't talk about during fluid electrolytes are the coag studies, and we'll talk more about that when we're doing hematology. But you do need to know PTT, normal PTT, partial thromboplastin time is 60 to 70, and then PT, your prothrombin time is 9.5 to 12. But now they're doing a new thing called INR, International Normalized Ratio. Normal is 1, but when you are putting somebody on anticoagulant therapy, you want a 1 to 2 or 1 to 3 ratio. We'll talk more about that a little bit later. And platelets, your hematocrits. When you're getting hematological studies, you get your CBC and then your hemoglobin and hematocrit to tell you how concentrated the blood is and how well it carries oxygen in the blood, and your platelets. Platelets are really important to know. That's about 150 to 450,000. The reason platelets are important is because you want to know if your patient is coagulating sufficiently or not. So look at that. Stress testing is very common. We put somebody under a stress test to determine their cardiac functioning, and a lot of you will probably end up working in stress labs, so I want you to look over that. Cardiac catheterization is also big. And a lot of times what they do is if they find out that somebody has a lot of cholesterol in their coronary arteries, they might start having angina, meaning like these are getting inflamed, and they might have a little cholesterol, but then they go back. They don't, so it'll cause a little bit of pain, a little bit of ischemia, but then it opens back up again. That's a dangerous situation, and it's a precursor for a heart attack. And so sometimes what they can do, the cardiologist will go in and do a cardiac catheterization, where they go in with an instrument, and they go down there, they can put a stent in, meaning it's like a little mesh that bounces open, and it opens up these arteries, puts a mesh in there to keep that open, or they can squish through the cholesterol and squish it out and open that up a little bit, or they can determine that these vessels are so badly clogged that the person has to go for a coronary artery bypass graft, and that is where they go in and they will actually remove some of these arteries, and they usually take the saphenous vein, the big vein that runs down the leg. They'll take this vein out and they'll bring it back up here, and they go out and around the blockage so that it can reperfuse that myocardium. That's called a coronary artery bypass graft. While somebody is having this done, try to go see one if you can. They're really cool surgeries. They have to crack the chest, so they saw right through the sternum, and then they put a patient on what's called a cardiopulmonary bypass machine, because while they're working on this, they can't have the blood going through it, but obviously you can't have your patient not getting blood everywhere for these surgeries usually take several hours. So we have a machine in the operating room that bypasses the blood from the heart, puts it over into this machine, oxygenates it, and puts it back and bypasses the heart altogether. And they keep them on that while they're having this. It's called we call it a cabbage. I'm sure you've seen this before. Coronary artery bypass graft, a cabbage. Very common. Big surgery, but lots of people have it, especially in the United States, because everybody has such horrible coronary arterial disease. So, okay, I think that's it. It's a heavy chapter. There's a lot Arterial blood pressure monitoring, that again is done, usually they put it, it's called an arterial line, and they put it right in the radial artery, like this. And then you don't put any medication through it. It's not like an IV. It's only for blood pressure monitoring in the ICU, or it's nice to have it in when you want to draw ABGs, because then you don't have to poke somebody, because you can go right into that artery and pull out arterial blood gases and send it to the lab. So you just do that if somebody has, they're hemodynamically unstable, their blood pressure's all over the place. You can put an art line in. Again, that's usually done in the ICU or the operating room. So I wanted to point that out to you. And okay, so that's kind of it. It's a heavy chapter. There's a lot to know in here, but it is so important that you understand these concepts, because everything else will affect this. So if you've got, COPD, if your patient is in renal failure and they're not peeing out, and all of a sudden you've increased your preload, and now that's going to affect your heart. So all of these things that we just talked about are affected in every other disease process, so you need to know that. So we'll talk more about it in class. I know it's confusing, but okay, that's it for today.